The challenge I felt with being relational in the clinic space, I think, is illustrated pretty well by this image I have of myself kind of standing in I think like my clogs in my office casual, like with my laptop resting on this ledge between kind of the medical pod and the patient hallway, kind of trying to look busy and surrounded by people in, blue scrubs, kind of rushing. People would kind of glance at me, kind of like, why are you standing here? And I was waiting. In retrospect, I was waiting for some sort of opening, a way to help, but also kind of a way to be known and to know. And at the same time, I think I knew that I could never completely, as a mental health provider, be a part of what I was seeing. And so there was just this sense of otherness that I experienced.
I remember many moments of trying to go to busy pods and meet patients that were there that were presenting with like high depression screener scores or had indicated they were tobacco users, and to try to offer support with care. And I would let the providers know that I wanted to come in. And I remember being so nervous just with that brief interaction. And I'd hang out in the pods waiting to have this like interaction that I thought would really help me finally connect with the patient, offer the service that I was here for. And then time would pass and the provider would come out and I'd be like, can I just, pop in the room for a second? And the provider was like, oh, they left like 10 minutes ago. I forgot. And it was like a total letdown. I was starting to integrate into a clinic where it was kind of known that they were reluctant to adopt behavioral health. So I knew I had kind of an uphill battle. And I remember sitting in this office with a doctor, older gentleman. He'd been around a while and he really made that known. And he was sort of like quizzing me on what cognitive behavioral therapy was. And so I was trying to, as smartly as possible, explain to him what it was, what it felt like to engage with. And I just remember his eyes like totally glazing over, didn't refer to me for months. And then one day I was like biking in and he saw me and he noticed my backpack and was like, oh, I have the same brand of backpack when I go backpacking. I was like, oh, you backpack. And then we started like jamming out on all this cool like ultralight gear and like what water filter he uses. And that was it. It was a great interaction. And then from then on, I would get referral after referral after referral. And suddenly it was like he knew me and wanted to use me.
Yeah, it didn't happen all at once. It was this experience, I think, of actually connecting about things that it had nothing to do with the medical space. I started talking about running with a couple of the providers, and I was actually new to town and I didn't know a lot of people, and they invited me to go running with them, which was scary for physical reasons, but and we started just talking when we would see each other in clinic about running. And while we were running, we would actually talk about work. And so it was kind of this like experience of sort of in both spaces, away from work and within work, kind of having things that we could share with each other that were sort of mutual interest. And I was really aware of just not wanting to sound like I thought I knew better. And I don't know if that was an effective strategy or not, but over time, what I noticed was that those folks that I was running with would now come to my office and ask me questions about how they could take better care of patients who were struggling with a mental health or substance use disorder. Once we got through the door, the sense that people wanted to listen and couldn't get enough and have wanted to interact with us has been overwhelming. to the point right now where we can't even, like in our program, manage the amount of demand, both from providers and nurses and for patient care. So it was sort of like, it's interesting to me in retrospect to think about, gosh, it really was just the running together, the talking about the backpack. It was those little conversations that humanized us and put us on some sort of plane where we were able to maybe I was able to stop making assumptions about what I had to say and the value there. Because a lot of it, I think, truly for me was just an assumption that what I had to bring to the table wasn't valuable because of how we kind of hold up medical providers in a certain way. And really caring about a lot of medical providers now, I know how powerless most of them feel. I wish I could kind of go back and whisper in my own ear, like, hey, like, they don't feel powerful either.
It was often those hallway conversations that turned into providers saying, hey, I'm really struggling right now. It helps for you to be here. Or I don't know how to talk about mental health. And so that's why I don't bring it up, because I already have too much on my plate. And that also helped me feel like, okay, maybe we're on the same playing field. And I'm in some ways creating my own walls that weren't intended to be there because of the perception of power kind of getting in the way of being able to build more authentic and collaborative relationships.
And so that really was our project, is how do RL skills show up in this work of integrating mental health care into physical health care? And so the way we ended up quantifying that was we just identified 10 medical providers, and we each interviewed a handful of them to really try to get at the elements of relational leadership that were kind of showing up as a part of this work. So really asking providers to reflect back on that past 6 or 7 years of interfacing with behavioral health. And we really just tried to get a sense for, remember how it was maybe before we were here, and then it was hard, there was a rough patch, we were here and it wasn't so great, and now we're pretty integrated. What do you remember about that experience? And then we recorded those conversations and we're really able to listen for themes. And we didn't have to try very hard, because it turns out the themes just popped up around relationship over and over again. What, providers said, I see this person as a part of the team. I started to trust this person. The person saw my patient had a good experience. I wanted more of that for my patients. Thinking about being an advocate in many ways to me is completely overwhelming. And I'm a social worker, which I think in some ways by kind of trade, I'm an advocate. But to me, advocacy seems big and kind of amorphous. I remember applying for RLI, and I actually remember writing my application, and I was in a space where I was kind of transitioning from being a clinician only to being kind of like a lead clinician and supporting other behavioral health people kind of to do the work, and really struggling with kind of this concept of being the boss and kind of being in charge, and what it means to kind of have what you would call power, even though, like, again, I didn't feel powerful, knowing that other people would find that I had influence. I remember writing in my application that I really wanted to understand more about how to have influence in a way that put relationships first. And so to me, to reframe when I think about advocacy now, what I think about is really those micro moments of influence that just build on themselves. So, I think a really powerful example is a practice I started while I was in ROI of stopping into, in and around kind of the nurses station and where the medical assistants sit, and just have a conversation before I started kind of going to see my own patients. And I realized over time that the people that I talked to were the people who came to talk to me about patients. And so that, I think, was where and after I finished RLI and all these pieces were coming together about one-on-ones and advocacy, I was like, oh, when I was asking her about her weekend, I was an advocate in that moment, because what I did was create a space for somebody from a mental health world to talk with somebody from the medical world. And that created a space to come and ask a question. And I had never thought of advocacy like that before. I thought advocacy was like you go and protest, or you go and like sign a petition, or you like propose something to an organization. And it really took RLI to help me realize that the one-on-one was the advocacy.
I think we both came to do integrated behavioral health for slightly different reasons, but primarily because we wanted to be a part of something that increased access to a much needed service of mental health and substance use disorder care. And for me, the goal was to just make that happen, to be there and be a part of that. And I remember sitting in, when I was a student of RLI, or sort of in my initial cohort, in that advocacy session, I was hearing some doctors from an OHSU clinic just really kind of grappling with this idea this question that I felt internally too: how else can we advocate? When will we have time for this? But also feeling more excited about kind of connecting with them about how do we create more collaborative community level change amongst clinics, though that also felt really overwhelming. Then fast forward to this research that Katie and I have been doing. What I think we didn't know was all of these micro moments of connection, the one-on-ones, the stories of self and call groups, the collaborative problem solving around patients, that led to people not only just thinking as behavioral health as a part of the program, but what helped them do their job better, what helped them to support patients better, what then also helped them to think differently and in a destigmatized way about access to mental health care. And so I would have never thought of myself as doing that advocacy work because I thought it would look like this high level change, and surely it wasn't. And I feel really, I hope this doesn't sound weird, but I feel really proud of that.